Good evening, everyone. Thank you for joining us today on a discussion on dry eyes prevention and management with Dr. Sayan Basu. This is part of a series that we've been doing with Eye Health, Eye Hope, on managing different eye conditions, chronic eye diseases. And today's topic is on dry eyes, which seems like a simple topic, but is actually, uh, not so simple. Um, just a reminder to everybody, Patients Engage is an online platform for patients dealing with chronic diseases and, and their caregivers to share personal experiences, information, and learn from each other. We do believe that the more informed patients are and their families are, and the more proactive they are in engaging with their own health, the better equipped and empowered they feel to make the day-to-day decisions that need to be made. And just by engaging with each other, it's a reminder that you don't have to fight any condition alone. You have a support network out there. Um, I hope for those of you who may not be aware, stands for Indian Health Outcomes, Public Health and Economics Research Center. It's a interdisciplinary research center set up with Wellcome Trust, DBT India Alliance, collaborations with LV Prasad Eye Institute, IIM Ahmedabad, and IIPH Hyderabad. And the focus of this center is big data analysis, health economics, clinical and public health research in eye health. And you can visit their website, ihope2020.org, for more information. Dr. Sayan Basu is Network Director, Research and Consultant Ophthalmologist at LV Prasad Eye Institute. Holds many positions. He's a clinician scientist and a key opinion leader in the field of cornea and ocular surface, and is recognized internationally for breakthroughs in corneal stem cell therapy. His research interests include dry eye disease, scarless corneal wound healing, and stem cell therapy, and he's worked with international scientists. And I'm Aparna Mittal. I'm the founder of Patients Engage and the moderator for this session. Just a reminder, the views expressed in this video are of the physician and are meant for spreading general awareness. They may not necessarily reflect that of the platform. The information does not replace a medical consultation. So for specific medical issues, please do discuss with your doctor. And you can post your questions on Zoom, on Facebook feed, as well as the YouTube feed, and we will try and address the questions in the next half an hour to 45 minutes. And you can always reach out to us either on our email at editor@patientsengage.com or our social media platforms, Facebook, Twitter, Instagram, YouTube, or LinkedIn. And the website is www.patientsengage.com. So let's get started because we have a lot of questions to cover. Welcome, Dr. Basu. What is dry eyes?
Hi, Aparna. Great to be here. And hello to everyone who's listening in. So, dry eye disease is a fairly common problem. And to describe it very simply, it's mainly defined by the symptoms that the patient has, which typically would be feeling that there's dryness in the eyes, irritation, foreign body sensation, etc. But these symptoms are not just restricted to dry eye disease. A lot of other ocular surface disease conditions can also cause dry eye. So once patients come in with this symptom, we usually do like a very initial workup, and based on a certain battery of tests, we figure out if the patient actually has dry eye disease or not. And just to explain it very simply, we have tears in our eyes to keep the eyes lubricated so that we have great vision and we don't have discomfort from the external environment or from constant blinking, etc. And when there is a change in either the quality or the quantity of the tear film in the eyes, or then that's basically what causes or what is known as dry eye disease.
So, you talked of the feeling of dryness. What are, the other symptoms of dry eyes, or is that the only symptom?
Most commonly, patients will complain of sometimes it's burning. So that's fairly common. I think almost 80 to 90% of patients with dry eye disease, the most common symptom that they complain of when the problem starts is burning sensation in the eyes. They may also complain of the inability to keep their eyes open for a long time, that they need to blink frequently. They may have trouble working for long hours or for continuously on any kind of a screen, whether it is a desktop or a laptop or any visual display unit, like even a tablet or a phone. And then, like I said, um, irritation, foreign body sensation, or just a general feeling of dryness in the eyes.
And is there also sometimes watering of the eyes?
So typically, that would be counterintuitive. So I think a lot of patients, watering by itself needs to be investigated, um, because there are conditions that actually cause excessive tearing, which can be because of blockage, which can be because of inflammation. Um, Classically, a patient of, we would not suspect a patient who is tearing excessively or watering to have dry eye disease, but there are certain exceptional conditions where you have patient has dry eyes, but also tends to complain of some amount of watering. But
Hmm.
those are very exceptional. When patient comes in and says that I have watering of the eyes, your first differential or what you suspect first is are typically diseases that are not dry eyes, but diseases that cause inflammatory conditions that cause excessive watering, or there is a blockage in the outflow of the tears from the eyes.
Right. And does dry eyes also increase light sensitivity or photosensitivity?
Yes, it can increase light sensitivity. A lot of patients who have severe dry eyes have difficulty in, working or going out into bright light, typically sunlight. Some patients may also complain of light sensitivity from something as innocuous as a screen.
Hmm.
We have to understand that most visual display units or screens nowadays, or all screens nowadays, the light per se is innocuous. It's not harmful at all, and it's not the light that causes any problem, but the ability, the threshold to tolerate the brightness or the amount of light is what gets affected. So patients may complain either of light sensitivity, that they feel that the light is too bright, but the brightness is actually normal, or they feel that they have what is called photophobia, which is that they're unable to keep their eyes open when they are exposed to normal uh, luminescence or normal light.
Right, right. So I know that we are all using much more screens, etc. And we are told not to use screens, but it's like fairly difficult not to. But is that the main cause or risk factor of dry eyes, or are there other causes and risk factors?
So, if you think of it based on what causes dry eye or dry eyes, um, this is an umbrella term that is used for different conditions that overall have the same symptoms and signs.
Hmm.
So, the tears that we have in our eyes, they are made primarily from two types of glands.
Right.
First and the most important gland is called the lacrimal gland, and the second are the meibomian glands. The lacrimal gland is present above the eyeball in the skull, and the meibomian glands are present in the eyelid. Now, these
Hmm.
are two different glands. The meibomian glands produce oil, and the lacrimal glands produce something watery, which is the major component of the tear film. These two mix together and form the tears. And just like when you mix oil and water, the oil floats on the surface. The secretion from the meibomian gland, which is oily, floats on the surface of the watery secretion from lacrimal gland, and that is what forms our tear film. The oil is important for lubrication. It is also important for the specific gravity which holds the tear film in its place. Otherwise, when you're standing up and looking ahead, the tear film would collapse if it didn't have that specific gravity. So you can have dry eyes either because the oil is deficient or not of good quality, or if the water is deficient. And as you can understand, these are two different glands which are being
Right.
affected, and so they usually don't overlap. So people either have meibomian gland dysfunction and what we call evaporative dry eye, or people have lacrimal gland dysfunction and what we call aqueous deficiency dry eye. You can have both conditions coexisting, but they are unrelated to each other. The way that these glands are affected are different. So broadly speaking, you have two different types of dry eyes, and therefore the risk factors for them are different. So
Okay.
when screen exposure is a risk factor for evaporative dry eye, which affects the meibomian glands. And this happens not because of the light, which like I said, is harmless. It happens because whenever, as human beings, we look at any surface which throws light back at us. For example, if you're reading a book, that's absolutely fine. But if you're using a Kindle, or even if you're using a tablet to read something, you blink less because that surface is lighted. So it's, we tend to stare at anything that throws light at us. And when we blink less, the meibomian glands, they are not squeezed as much. So every time we blink, close our eyes and open, the muscles squeeze the meibomian glands in the eyelids and the oil comes out and that lubricates the surface. This doesn't happen. And therefore, the amount of oil on the surface is deficient. This leads to a quicker evaporation of the tear film from the surface, which is called evaporative dry eyes, which is related to screen time. So if you're talking about evaporative dry eyes, definitely excessive screen time is a risk factor.
Right.
But it has nothing to do with aqueous tear deficiency, which is mostly because of autoimmune diseases or immune-related conditions.
Okay. So are so therefore you're saying that the two causes and risk factors are either as you said, screen time, which affects the evaporative dry eyes, or it is autoimmune conditions which affect aqueous dry eyes. Okay. Are there other risk factors that may be there, like aging or genetics or any of those other risk factors?
So for evaporative dry eye disease, there are definitely, because the meibomian glands are essentially derived from they're modified sebaceous glands, which are present in our skin. So surface of the eye is, it evolves from modification of the surface of the skin. So the sebaceous glands that are there in our skin are basically modified as meibomian glands in the eyelids. So conditions that affect the sebaceous glands, like for example, very commonly acne, also causes meibomian gland dysfunction. So those people who have a lot of acne tend to also have meibomitis. And therefore the conditions, the risk factors that are likely to cause acne, for example, hormonal influence. So you would see it more often in young adults. It is also associated with other hormonal conditions like PCOD, etc. And its treatment can cause meibomian gland dysfunction and evaporative dry eye, other than screen exposure. So those people who have these two factors coexisting, they're more vulnerable to develop dry eyes or have more severe form of evaporative dry eye. For aqueous tear deficiency, since autoimmune disorders are risk factors, there are certain autoimmune disorders definitely which have a genetic basis, and therefore that can be. And then there are conditions where certain procedures, like if somebody's had a bone marrow transplant for leukemias, they can develop something called a graft versus host disease, which can also cause immunological damage to the lacrimal gland and cause dry eye. So then that becomes a risk factor because somebody's had bone marrow transplantation.
Right. And for those of you who watching, we are talking to Dr. Basu on dry eyes. And if you have any questions, you can leave them. You can either add them in the chat here on Zoom, or you can leave them on the Facebook or YouTube feed. Are there staging of dry eyes, right? So does it start mild and does it progress over time?
Yes, some forms of dry eye disease definitely are progressive. So evaporative dry eye is usually not progressive. It's something that is, doesn't really get worse with time. But as long as somebody has evaporative dry eye, the symptoms remain, and that needs to be addressed. But aqueous tear deficiency definitely can be progressive, and somebody can go from having very mild disease to very severe disease where they don't have any tearing at all. So like I said, evaporative dry eye is mostly because of meibomian gland dysfunction, and it's a qualitative change in the tear film that leads to excessive evaporation. But the overall bulk of the tear film in terms of the aqueous component is retained. So it can't get very bad beyond a certain point. Although you have certain patients who do develop, but it's a severe disease, but it's a very small proportion. So evaporative dry eye in that sense is the milder form. It is in general non-progressive, although it can be chronic and quite annoying. Aqueous tear deficiency definitely is the more severe form. It can go from bad to worse. It can be potentially blinding, and it can cause complete deficiency of tears as well.
Okay. And therefore, are the treatments for both of these types of dry eyes different, or is the treatment the same?
They are completely different. So, like I mentioned before, I think we should, at least when somebody has been diagnosed with dry eye or is being treated with dry eye, the diagnosis of dry eye disease should be qualified by whether they have evaporative or aqueous tear deficiency. I find this, there are a lot of patients who have been on treatment for dry eye disease, don't know, they have never been explained the difference, and this is problematic because the underlying cause is not addressed. And if it is treated in the same way, you cannot give the patients, the the precise treatment that is required, or customize it based on the underlying problem. And therefore, most of them are unsatisfied because they are getting a generalized treatment for dry eye in general, which doesn't mean anything unless you know what is causing the dry eye. So for somebody who has evaporative dry eye, the treatment is targeted at the eyelids and the meibomian glands. So there are certain forms of treatments that can help reset the meibomian glands, or make them completely functional again. There are certain things that you can do yourself that are easier and helps with the meibomian glands functioning normally. So the most common thing that, and most easiest thing that you can do is blinking, because that is, like I said, the thing that started the problem in the first place. Lesser blinking because of screen exposure. It's of course very difficult to ask somebody to blink more, because it's like asking someone to breathe more, because blinking is involuntary. But you can take blinking breaks, which are very helpful. So somebody who spends a lot of time on a system or on a screen can remember to take blinking breaks, maybe one in half an hour or so. Just close your eyes for a few seconds and then blink 15-20 times. That in itself makes a huge difference. You can also do something called strategic blinking, which basically means when you start getting symptoms, or you've spent a day binge watching OTTs, or you worked on a presentation, or you've been traveling, you've been in air-conditioned environment for a long time, and typically these are triggers that will make you very symptomatic the next day. This is typically what happens to patients with evaporative dry eyes. And then to prevent that, you can end the day by just doing blinking exercises, or even doing warm compresses with blinking. The warm compresses essentially are just transferring some amount of heat to your eyelids. You can either do it wet with a cloth, or you can, nowadays you have these microwavable pads that you can put on the eyelids. So that helps. So this is the treatment for evaporative dry eye. And then you have adjunctive or supplementary treatment with lubricants or artificial tears. Whereas for aqueous deficiency dry eye, it's completely different. The underlying disease needs to be diagnosed, that needs to be treated. So a systemic treatment is necessary. Anti-inflammatories play a very big role in aqueous tear deficiency. Many patients would also require certain surgical procedures to correct other problems that they have, which can give them systemic relief. So again, in terms of, not just in terms of the cause, but in terms of the treatment also, the treatment of evaporative dry eye and aqueous deficiency is completely different. The only thing common is the use of lubricants, which are for symptomatic relief, but they are not targeted towards the disease pathology.
And the lubricants for both are the same, because often people, lubricants are available in OTC, right, from a chemist directly. So people often kind of start with that. So is that the same for both types of dry eyes?
They are actually not the same, but there's a very subtle difference. So you can broadly classify the over-the-counter lubricants. In fact, all lubricants are over-the-counter.
Right.
Two types. The first type essentially are the ones which are less viscous.
Hmm.
This is typically a carboxymethyl cellulose eye drop, which is 0.5%. We prescribe this for patients with aqueous tear deficiency because they need eye drops more frequently, and this is lighter and better tolerated. And then you have the more viscous lubricants, which are either hyaluronic acid or hydroxy propyl methyl cellulose, HPMC, or something called polyethyl glycol, or PEG. These are more viscous and these are more retentive. So it's better to use them in evaporative dry eye where you're trying to retain the tears for a longer period of time. There's no actual deficiency, but just the evaporation is faster and therefore leading to symptoms. So actually it is different. However, this difference is subtle. So a lot of times people are using the more viscous lubricants when patients have aqueous deficiency, or using the less viscous lubricants when they have evaporative, which is also not correct.
Right. And a couple of questions that have come. I think somebody's asked if icing helps. I guess you said warm compresses, but somebody's actually asked about icing.
Again, warm compresses will help if you have evaporative. Icing will help if you have aqueous tear deficiency, because icing essentially causes vasoconstriction. It causes the blood vessels to shrink. And therefore, if you have an underlying inflammatory cause, then if you apply ice, then it reduces the pain, the discomfort, it makes you feel better. But if you use ice, if you have evaporative dry eye, and if you're using ice, it will block your meibomian glands even more, and it will worsen your symptoms. So again, it depends on what kind of dry eye you have. So if you have inflammatory dry eye, which is aqueous tear deficiency, icing definitely helps. In fact, in some patients, we also advise them to keep their eye drops in the fridge and use it, slightly cold at 4 degrees, so that they have the additional comfort of, the anti-inflammatory effect of using something cold. But if you have evaporative and if you're using something cold, it can make things worse.
Right. And somebody's asked, can diet or increase in intake of water help?
Not really. So what makes tears from your eyes is tears are essentially filtered from the 5.5-6 liters of blood that is flowing through our veins. Okay. So if you drink more water, it does not mean that your blood volume increases or that your wetness in the eyes can increase. That's actually not true. So drinking excessive water does not help. Having a good diet absolutely helps. It helps with everything. So if you have a healthy lifestyle, if you indulge in a healthy amount of physical activity, if you have a very balanced diet, that helps with everything, because the eye is not separated from the body, and therefore your likelihood of developing autoimmune diseases or other problems that can make your dry eyes worse are much less if you are overall healthy. So yes, being healthy definitely helps with everything.
Right. So, talking of a couple of those other things, lifestyle related, does sleep play a role at all in any of the dry eyes? Yeah, let's talk of sleep first.
Sleeping well does help. Um, if somebody is sleep deprived, that means your body is stressed. And if your body is stressed, then in that state, anything that is causing problems in the body, it just becomes worse. Okay, so sleep not directly in terms of how long your eyes are closed, but in terms of the stress it induces in general in the body, because you are sleep deprived or you're not rested enough. That can, if you have dry eyes, it can make it worse.
Okay. And if because people with dry eyes also have light sensitivity, again, just as you said, you can do more blinking exercises. Does that help for when you're out in the light, or not really?
It can help. So those people who have particularly evaporative dry eyes and they have light sensitivity, blinking exercises, warm compresses do help in, those patients. Yes.
We've just got a question. I use contact lenses, and does that also cause dry eyes?
Contact lenses per se don't cause dry eyes. They can cause sometimes if your contact lenses are actually very safe. Firstly, second is that if you take care of your lenses, if you clean them properly, if you dispose of them as recommended, for example, if it's daily disposable, you use a new lens every day. If they're monthly disposable, you use a new lens every month. You use the correct type of solutions. You don't sleep with your contact lenses on. Then nothing bad will happen. Contact lenses that are currently in the market are extremely, extremely, extremely safe. So they can cause other problems if these precautions are not followed. And typically, but if you have subtle dry eye and you are a contact lens user, you will definitely become symptomatic very easily. So the common symptoms that you can have if you are using contact lenses and if you have dry eyes that you don't know about is that your eyes become red very easily with a few hours of contact lens wear, or you start to feel discomfort with the lenses on.
Right. Okay. And while we wait for any other questions that come in, what happens if you don't treat dry eyes? And again, I guess for both types of dry eyes.
If somebody has evaporative dry eye, it can really impact their quality of life. It becomes very difficult for these patients to spend long hours on a system. And if you are not able to use a computer or a system for many hours per day, it becomes very difficult to work, irrespective of what kind of work you're doing. Okay.
Correct.
Even for us doctors, we have to spend a significant amount of time on computers because most of our medical record systems are electronic, etc. So that it becomes, in some cases, can become disabling. There are some people who quit their jobs because they're not able to work anymore. And if you have to, particularly people who are in the IT industry or the IT sector, where their timings have to match those of MNCs, and therefore they have to do night shifts, etc. So it becomes particularly difficult for them because if they are not able to spend or work comfortably on the computer. And for those who have aqueous tear deficiency, it can, if not treated, diagnosed and treated very early, it can progress. You can get a lot of inflammatory complications in the eye. The corneas can get damaged. And like I said, aqueous tear deficiency actually is a very serious condition that is potentially blinding. Unlike evaporative dry eyes, aqueous deficiency dry eyes are potentially blinding. And therefore,
Right.
the underlying autoimmune disease needs to be recognized and needs to be treated very early to prevent that progression.
So somebody is asked, and this is someone with the autoimmune condition. Usually only a Schirmer's test is done for assessing the level of dryness. What tests need to be done to evaluate which type of dryness it is?
So the most important test that needs to be done is called staining of the corneal surface. Usually the fluorescent dye is used to do that. So your dry eye specialist or your cornea specialist or your ophthalmologist should stain your eyes to see how severe the problem is, number one. The Schirmer's test, if done well, is quite informative, but the Schirmer's test is very unreliable and it can give variable results based on the external, the environment of the room that you're in. For example, if you're sitting directly under a fan or an air conditioner, your Schirmer's readings can be falsely low, and that can exaggerate the amount of dry eye you have. So we usually do use the Schirmer's test, but it is not very reliable unless you're doing it in the right way, which often it is not. So there are other objective tests. We typically call this a comprehensive dry eye evaluation. It consists of 3 tests, which are usually done on a machine on which you keep your chin, just like a slit lamp, and the machine takes some readings without any contact. These tests are called the tear meniscus height, the non-invasive tear breakup time, and meibography. Meibography is essentially infrared imaging of the meibomian glands. The non-invasive tear breakup time or NITBUT, it measures how fast your tear film breaks up on the eye when you stare, when you don't blink. And your tear meniscus height essentially measures what is the height of the tear film in the eye. So these three tests are very, very important. They're objective, they are repeatable, and they're more reliable than the Shermers.
And talking of testing, then once you are diagnosed with any of the two dry eyes, are you supposed to go for regular checkups or follow-ups? Is there a protocol for that?
So patients with evaporative dry eyes, we first try to explain to them why this is happening, what they can do to reduce their symptoms and make them more functional. Like I said, blinking and warm compresses, etc. And then, using lubricants as and when needed. And if, 90% of the times this is enough. And evaporative dry eye patients, although, like I said, both conditions are chronic.
Right.
So it is, these problems don't completely go away. But if the patients with meibomian gland dysfunctions are taking care of these things, they are able to function well and keep their annoying symptoms at bay largely. And they don't need to come in and see the doctor all the time. Only when they have some kind of a spike in inflammation or symptoms, etc., or something goes wrong. If these patients are not able to do these things, or despite doing all of these things, they are still symptomatic or still not able to function, then there are certain targeted therapies for the meibomian glands. So the very popular treatment for this is called the LVPEI. So the LVPEI, you basically lie down on your chair, and there are applicators which we put on the eyelids. And then basically it's a system where warm water flows in through those applicators, and it gives a little bit of pressure on the meibomian glands and this is essentially massage delivered in a very standardized way to the meibomian glands directly. There is also something called intense pulse light therapy. This is again borrowed for dermatology. Like I said, meibomian glands are modified sebaceous glands. So just IPL is essentially, there's a flash of very bright light that is given. Your eyes are of course closed. It stimulates the parasympathetic nerves in the skin that help in opening up these glands, both in the skin. So it was initially developed for acne, but it can also be used for meibomian gland dysfunction and evaporative dry eye. So that's for this part. And for aqueous tear deficiency, if things become, they do need to follow up with the doctor, both with their rheumatologist who are treating their underlying systemic condition and with the ophthalmologist. I would say every 3 to 6 months.
Right. We've got a few questions coming up. I have mixed dry eye disease, but my ophthalmologist says there's no evidence, or my physician says there's no evidence to state it is autoimmune. What can be causing the aqueous deficiency? And for mixed, do I use hot compress or cold compress?
So like I said, this is a lot of people have this question, and I think that even if you have coexistent aqueous tear deficiency and meibomian gland disease, usually one of them will be dominant. It's very rare to have very severe meibomian gland dysfunction combined with aqueous tear deficiency. It happens only in very rare conditions, which are also very difficult to treat. But for most people, it's important, it's imperative to understand what underlying pathology is causing this. So is it the component of aqueous tear deficiency which has the upper hand, or the meibomian gland dysfunction? A lot of times when we are not able to distinguish, we say it's mixed. That's actually not correct. I mean, for patients who are coming into my clinic, the diagnosis of mixed dry eye is less than 5% of all patients with dry eye. Meibomian gland dysfunction is probably around 50-60%, and the remaining 30 to 40% have aqueous tear deficiency. Even in literature, if you see, mixed dry eye is the least common form, and mostly mixed dry eye is a I would say, an inability to figure out which component is greater. But if you have aqueous tear deficiency and that has been established, then definitely, that would be priority for treating. So if you look at all the causes of aqueous tear deficiency, they are all immune mediated. So one cannot have aqueous tear deficiency without an underlying immune mediated etiology. However, you can have certain problems that mimic aqueous tear deficiency, and this is very, very important. So if somebody is on any kind of neurological medication, most commonly sleeping pills. So if you're, using sleeping pills regularly, or anti-anxiety, antidepressants, these medications do cause something on the surface which mimics dry eyes. It's not a true lacrimal gland insufficiency or aqueous tear deficiency, but the gland is just slow to respond. So when we examine the gland directly, we see that tears are oozing out, but they are oozing out very slowly because the medications are slowing down your system, because they affect the central nervous system directly, and just the threshold for everything is more. So if you have been diagnosed as mixed dry eye, you have some component of aqueous tear deficiency, but you do not have an underlying autoimmune disorder. It could be your medications that are causing this.
Okay. Thanks. I think that's very useful. There's one more question is, what about people who've had cataract and they have dry eyes? Which category would they fall into, or does that not, do they have to assess that?
No. Usually it's not aqueous tear deficiency, but usually it's evaporative dry eye. So what happens is, two things can happen. There are two surgeries which can worsen your dry eyes. One is cataract surgery and the other is refractive surgery. Refractive surgeries like LASIK, etc., that people get done to get their glasses removed. What happens after cataract surgery is that the medications that we use after cataract surgery, the eye drops, which are usually a combination of steroids and antibiotics, because they are used for a certain period of time, they can often cause transient blockage of the meibomian glands. Okay, and therefore again, you can make your you can develop meibomian gland dysfunction after cataract surgery because of this problem. It's usually related to eye hygiene. A lot of times the hygiene is not optimal after cataract surgery when they're using the drops, and that causes blockage of the glands. The other possibility is that somebody with a subtle preclinical form of dry eye, after cataract surgery, the dry eye manifests and then it becomes worse. But what you have to understand is whether your symptoms are, so dry eye is by definition a bilateral condition. So if you are only symptomatic in the eye which has had cataract surgery, it is probably evaporative dry eye because of the eye drops that you used after that. It can be cured completely, and blinking does help. Lubrication also helps. A little bit of improved lid hygiene can make a lot of difference.
Okay, thanks. One more question, which has come in on allergies. 1 second, let me read it out. Can dry eyes be an outcome of severe allergies? Assuming severe allergies lead to release of histamine, and hence doctors have recommended antihistamine.
So both dry eye and allergies come under the broad heading or grouping of ocular surface disease. Okay. However, they are completely different diseases. The underlying pathology is different. I know that a lot of times people use these diagnostic terms in a very loose way, and sometimes that leads to a lot of confusion. But typically, patients with allergy have the exact opposite of dry eye. They might have certain similar symptoms like light sensitivity or irritation or itching, etc. But mostly patients with allergy have watering and not dry. So you will see that these are patients, who have puffy red eyes and their eyes are watering. The dry eyes are usually exactly the opposite.
Right. Somebody's asked, what is scleral lens?
Okay. So scleral lens are special types of lenses which are fluid filled. We use these lenses for severe forms of ocular surface disease and non-responsive forms of ocular surface disease. So like I said, it can be used for allergy, it can be used for dry eyes as well. It is very, very useful in patients with severe forms of aqueous tear deficiency for two reasons. One, because the surface in the corneal surface, the ocular surface in these patients, or the surface of the eye in these patients is irregular. They don't have clear vision. When you wear these lenses, because the surface of the lens is very smooth, they can see very clearly. And the second is the lens are vaulted. So there is a gap between the lens and the cornea or the eye. And these are fluid filled. So there's this fluid in this. So the lenses are actually filled with fluid and then put in the eye. So the fluid hydrates the eye and then gives you comfort. So it's very useful in aqueous tear deficiency in patients with severe, intolerable, recalcitrant meibomian gland dysfunction who have undergone everything but are still symptomatic. They need to work in the system, but they can't. Again, scleral lenses come in very handy. Also, another thing that we use sometimes, they're called autologous serum eye drops. Autologous serum eye drops are essentially filtered blood. Like I said, told you in the beginning, the tears are essentially biologically ultra filtered blood that is being secreted into. So it's transparent and it's watery, but the body essentially makes it out of the blood which is running, circulating in our body. So we can do it externally as well. So we can draw some blood and spin them down and take the clear fluid and make it into eye drops.
Right. Thank you. For autoimmune related aqueous tear deficiency, is restasis enough or oral steroids are needed?
Both often are needed. Restasis is an excellent topical anti-inflammatory agent. You can use topical steroids as well. Topical, by topical, I mean eye drops essentially. So you can use steroid eye drops. You can use restasis, which is essentially cyclosporin. It's a steroid sparing immunosuppressant medication. The difference between the two is that steroids are more potent, but if you are using steroid eye drops or oral steroids for a long term, they are associated with a slightly more problematic side effect profile. So, for example, if you use steroid eye drops for a long time in your eyes, you can get glaucoma, high intraocular pressure, and optic nerve damage, or cataracts. Cyclosporin causes no such problems. So, typically, for when patients are very symptomatic, we give them steroids, but we maintain them on restasis. So, often patients will be on something like restasis for the long term, but will often require short pulses of topical steroid eye drops. They may also be given systemic steroids based on the underlying condition. So one of the important causes of aqueous tear deficiency is a condition called Sjogren's syndrome, where you have dry eyes, dry mouth, dry skin, and also joint pain. Now you have to understand that all of this is because of the same mechanism, that the blood is not being converted into a fluid. So it's not, the body is not making enough saliva in your mouth. It's not making enough tears in your eyes. It is not making enough sweat and oil on your skin, and it is not making enough fluid in your joints. So the problem is the same. The manifestations in different parts of your body are different.
Right. Thank you. Two final questions. I think there's one on Zoom. What type of dry eyes is caused by sleep deprivation? I guess it's evaporative, right? But I will let you answer.
Yeah, so it mostly will be evaporative. Aqueous tear deficiency, like I said, it can be caused by a very specific number of disorders, which are all immune mediated. So I'll just list them out in case you've heard of them. Sjogren's syndrome, which can be primary or secondary. Secondary Sjogren's syndrome can be because of rheumatoid arthritis, can be because of lupus, or they can be because of very rare diseases which are characterized as cicatrizing conjunctivitis. This includes Stevens-Johnson syndrome, pemphigoid, and another disease which happens, some patients develop this after bone marrow transplantation, called graft versus host disease. Graft versus host disease, GVHD. So right. This is, what causes aqueous tear deficiency. They are all immune mediated. So you can't develop an immune mediated disease just because you're sleeping less. Everything else is evaporated.
Right. Thank you. And the last question is, what about prickly sensation along with severe dryness on the eyelids, especially at night or waking at night because of this? What
so this could be, sometimes you get a, I don't want to scare you, but sometimes you get something which is similar to lice in your hair. So you get a parasitic infestation in the eyelashes. Okay. And this causes this kind of prickly sensation, and you actually have this kind of micro pain near your eyelid, especially where the lashes are, especially at night. So it's very similar to any kind of parasitic infestation, and this can be cured completely if you improve the hygiene of the eyelids. So just by scrubbing your eyelashes with a Q-tip or a earbud dipped in diluted shampoo once or twice a day, or once in a day is enough, I guess, and by using anti-inflammatory ointments at night. So if you have this very specific complaint of this kind of biting or painful prickly sensation on your eyelids, especially at night, this can be because of this parasite, which is called Demodex.
Okay, and on the lid question, there's one just come in, and this I promise is the last one. Lid viper epitheliopathy. Is this inflammatory or immune mediated allergy? What is it, and what should I do?
So patients develop lid viper epitheliopathy if the part of the eyelid, so the entire eyelid does not come in contact with the eye, of course. In fact, the anatomy of the eyelid is such that only a very small sliver or strip of the back part of the eyelid, which is facing the eye, comes in contact with the eye, not the entire back surface. It's a very small strip, which is called the lid viper. And basically, it means that it is part of the lid that wipes on the cornea, just like your windshield wiper wipes your windshield. If there is any problem in that part of the eyelid, then it can corrode or cause friction or cause problems on the surface of the eye because of rubbing against. There's an uneven surface rubbing against your eye. Lid viper epitheliopathy. This is basically what lid viper epitheliopathy means. So the part of the lid which has the viper has a problem, and it is causing epitheliopathy. Epitheliopathy means the epithelium that is covering the surface of the eye is getting damaged. Most commonly, the epithelium covering the cornea. Lid viper epitheliopathy most commonly happens in a condition called Stevens-Johnson syndrome. Not when patients develop Stevens-Johnson syndrome, but many months or years after they have recovered from Stevens-Johnson syndrome because of a very specific change in the lid viper area called keratinization. So skin starts growing back and it irritates the eye. It can also happen in any kind of chronic condition, like, for example, somebody who's had allergy for several years and has been on several kinds of eye drops can also develop a similar change. It's an inflammatory change in that small strip, that area called lid viper, and that can damage the eye and cause irritation and symptoms. So if you have lid viper epitheliopathy, what you can do is scleral lenses will help. Also, there's a surgery called mucous membrane grafting, which can completely get rid of the symptoms.
Okay. Thank you so much, Doctor. I think we addressed a lot of questions. I think this clearly was a topic which hardly gets talked about, and we had a lot of people who joined and asked a lot of questions. So thank you for taking so much time on a end of your day. And thank you to the audience for asking your questions so that it helps so many others who may be listening as well.
No, thank you, Aparna. It was a pleasure. I just want to leave everyone with one message, that if any one of you or anyone in your family has been diagnosed with dry eye disease, please ask your ophthalmologist whether it is evaporative or aqueous tear deficiency. And if they don't know how to make that distinction, please ask them to refer you to somebody who can.
Right. Thank you. Thank you so much. And I think that is, please do advocate for yourself to find out which type it is. And that's very important. Thank you. Thank you once again, Dr. Basu, and thank you to our audience as well.
Thank you. Bye-bye.
Bye-bye.